when mums ask me this question, I always say you can do whatever you want. You know what I mean?
Yes.
If you do not have an epidural, because an epidural, there's no sensation. You know, there's no motor sensation. There's no motor power in your legs. You can't stand, or you can't squat, or you can't be on all fours. And some end up having an epidural, which is fine. But if you're not having an epidural, then you can move around and do whatever you want. And find whatever is useful for you. And some women like to change positions, some women prefer to lie down or whatever it might be. But my role is basically when you run into trouble. I don't know whether all obstetricians would agree with me, but I do see it that way. My role is, if things are progressing well, then all fine and good, you know? Yeah. However the baby, or whichever position the mom wants to be in. But my role is, if things are not progressing well, or if there's a problem in labor, that's where I have to come in and assist and perhaps start up some medication to optimize the contractions, or to look out for potential problems, as in one has a fever or things like that, whatever it might be, or fetal heartbeat abnormalities. And then not uncommonly at the end, sometimes the first time moms have trouble pushing. I mean, they're doing whatever they need to be doing, or whatever they have to do. But some do have trouble pushing at the end, and that's where we assist with vacuum or forceps in some cases. So prior to that, it can actually be in whatever.
So if they put in the birth plan that I want to be like in a squat or side lying or in all four.
It doesn't matter. Honestly, to me it doesn't matter. Sometimes, but I do tell them sometimes with these birth plans that sometimes things may not go according to plan. And I think that is reasonable, and I think that's something that which moms should be aware of, because labor is fairly unpredictable, you know, especially for first time moms. So as long as they understand that, then they, I think it's reasonable what they do.
I'm super fond of the last birth that I did with you, where the baby is like coming out, you just chill and just stand there and just like watching, and there's no like rush. Everything was so smooth, like going for a spa kind of feeling. And
Okay.
Yes, and I mean that's really nice, and my client had such a fast birth, and
I think it's fine. Actually, the data does show that delayed clamping does improve the hemoglobin or the iron stores in the baby, because just breast milk alone, I believe some of these babies may run into mild iron deficiency if they do not start weaning so much. If they start weaning at about 5 months, 6 months, which is the time, they might be mild iron deficiency. So it does improve iron stores in the baby. So I think it's quite reasonable to do it. Obviously, the baby does need resuscitation. The baby's unwell, you have to re-clamp and have the baby attended to.
So for your delayed clamping, do you like gauge based on like the duration? If they say that how long do you allow delayed clamping to be?
So typically we will delay the clamping for about a minute or so.
If any of the
sometimes they may require longer. So generally we would delay until the cord stops pulsating, which is roughly around that time.
Some of the Chinese did say that 2 minutes and all those things. So
I don't think there's as far as I know, there's no. Usually I would go by it stopping pulsating, which is typically in that sort of time.
How about the more and more of my clients also like asking direct skin to skin contact, and not to do all the necessary items.
Yeah, I mean, again, this is a common thing that a lot of moms bring up. I always tell them, once the baby's out, you can do whatever you want. Baby is like your child, right?
Yes. Yes.
So, I mean, sometimes the nurses want to do this, do that. Okay, like if the baby is unwell, then clearly they have to do the necessary. But if the baby is well and it's crying, because your child, you can do whatever you want with it. I'll just focus on the suturing.
Yes,
and you can hold the baby, you can like feed, or you can skin, do whatever you want. You know?
Yes.
Sometimes they will dry it off, because baby's wet when it comes out, so it needs to be like dry, right? So otherwise it will get cold, right? Like it's like coming out of swimming pool and not dry. But apart from that, you can do whatever you want.
I have
personally, most of my patients will tear. I do have a discussion with them some weeks before birth about all these aspects of labor, what to expect, the tearing, pain relief options, what happens if something doesn't go to plan. So I will discuss with them regarding what happens during labor with regards to the tearing. So for most of my patients, they do tear naturally, even first-time moms. We just have to try to reduce the degree of tearing by using warm compressors and things like that. But it is not uncommon. Most first-time moms will tear. Some lucky ones don't tear even though the baby is quite sizable. But it's more likely to tear, less likely to tear with a smaller baby.
Yes.
I do make episiotomies in certain circumstances if we need to expedite the labor. For example, if there's certain fetal heartbeat abnormalities. And in some women, sometimes the perineum swells up a lot. There's a lot of perineal edema, and that doesn't tear well. Sometimes it tears badly. In some cases, some women we do get tears in other places sometimes if we do not make an episiotomy, which I know that happens. Sometimes there will be tears at the sides or near the urethra or near the clitoris. Sometimes the higher tears in the anterior portion, which need to be repaired. Usually the healing goes okay, but that's a downside if you do not make an episiotomy. But sometimes there will be tears at the side. However, I do not think it's so good to have the perineum. There have been some occasions, in the past where the lady declines an episiotomy, so the head is distending the perineum for a long time. And for some reason it just doesn't tear, or the lady doesn't push that hard, so it just stuck there for quite some minutes, sometimes 5 minutes, 10 minutes.
Oh, that's long.
Yeah, quite some minutes. Usually the first time ones. And these can result in tears higher up, yes, they can result in vulval vaginal hematomas, which are more troublesome, which require deeper suturing, evacuation of the clot, and things like that. So there's a bit of a downside to it. Sometimes these things, I mean, in obstetrics, because something is coming through, there's some tearing of various blood vessels are torn. Tears can occur in various places. Yeah, but I don't routinely. But yes, back to where I was. So I do make episiotomies in certain circumstances when we want to expedite the delivery, or when we anticipate a bad tear.
Yeah, I think that's fair.
Yeah, and in some cases, when I do assisted delivery, some assisted deliveries are what we would call easy. The head comes down nicely, the mum pushes well when we do the traction with the vacuum or the forceps, it comes down nicely, and then the perineum distends nicely. In a few cases, assisted delivery can be quite hard, even though the baby is not so big. Sometimes the baby is in occiput posterior position, sometimes the baby is bigger, sometimes the mother does not push well, sometimes it's everything, plus fetal heart rate abnormality. So in these cases, we want to get the baby out quickly because we don't want to keep pulling on the baby's head over 10 minutes. It's not safe for the baby. So in that case, we would suggest an episiotomy as well to just expedite the delivery.
I think that's really fair because it's more like a medically required kind of situation that the procedure is done.
Yes.
Okay.